During forelimb amputation, the patient is placed in lateral recumbency with the affected limb uppermost. A teardrop-shaped incision is made around the extremity. The incision is begun on the lateral aspect of the spine of the scapula and then brought across on the medial aspect, as you can see illustrated here, to connect the incision from the lateral side. The surgeon begins the incision at the top of the scapula, running the incision in a nice, smooth, continuous fashion down the lateral aspect over the spine of the scapula. The incision then forms a teardrop with the caudal aspect across the latissimus dorsi and into the axillary region, and the cranial aspect across the scapulohumeral joint. The leg is abducted, and the two incisions are connected by a medial incision across the pectoral muscles. Care is taken just to incise the skin and subcutaneous tissues. The large cutaneous vessels on the lateral aspect of the limb are identified, doubly ligated, and incised between sutures. The fascia just distal to the omotransversaris is dissected with scissors, and the scissors are then placed in the plane between the omotransversaris and the trapezius muscles. The scissor is then withdrawn, and this incision along the spine of the scapula to remove the omotransversaris and the trapezius directly off of the spine. Care is taken to try to preserve as much muscle as possible. The caudal aspect of the trapezius muscle is also excised. A blade is then used to remove the rhomboideus muscle from the cranial and dorsal aspect of the scapula. And then the serratus ventralis muscle is dissected either with a periosteal elevator or with scissors. The brachiocephalicus muscle is then cut on its attachment on the humerus. The scapula is avulsed so that the brachial plexus is easily identified. Bundles of nerves are injected with bupivacaine. The nerves are identified and transected. Here you can see the scalenus muscle deep to the axillary region. Once the nerve bundles have been injected and transected, the surgeon is careful to evaluate the axillary region and make certain that all of the nerves are injected and transected prior to exposure of the axillary artery and vein. Here you can see the nerve bundles are being cut sharply, and this can be done either with scissors or a scalpel blade. The axillary artery and vein are identified and individually ligated. Here you can see the axillary artery is having an encircling ligature placed around it. A second encircling ligature is placed. The axillary artery is ligated with an encircling ligation, followed by a transfixing ligature on the distal aspect of the axillary artery that will remain with the patient. The artery is then transected, and you can see that 2 hemoclips have been placed to prevent back bleeding from the distal aspect of the remaining axillary artery. The thin-walled axillary vein is identified and dissected, and an encircling ligature is placed around the axillary vein, and in most cases a double ligature without transfixation is all that is necessary for the easily crushable thin-walled axillary vein. Once the artery and vein have been ligated and transected, the leg is then replaced back into its normal position, and the latissimus dorsi is carefully dissected, and care is taken to identify the lateral thoracic artery, vein, and nerve. In a large breed dog, this can be quite a sizable vessel and does require ligation. Here you can see the surgeon is carefully dissecting any loose connective tissue on the area of the latissimus dorsi that inserts on the humerus. Care is taken to preserve as much of the latissimus dorsi muscle as possible, as this muscle will become a protective mechanism to the patient's chest wall. Here you can see the surgeon has identified the lateral thoracic artery, vein, and nerve. The vein is easily identified, and the artery and nerve run very close to the vein. These are individually ligated and transected before the latissimus dorsi is amputated off of its insertion on the humerus. Once again, the surgeon is careful to try and preserve as much of the latissimus dorsi as possible. The extremity is then abducted, and the pectoral muscles, both the superficial and deep pectoral muscles, are excised off of the attachments to the humerus. Again, it is important to protect and save as much of the pectoral muscles as possible, as they will also offer a protective covering of the patient's chest when the leg is amputated and removed. Any remaining loose areolar connective tissue in the axillary portion of the patient's extremity is carefully excised and amputated, and the limb is removed from the surgical field. The area is lavaged. Care is taken to make certain that all bleeders have been adequately ligated. The pectoral muscles are brought from distal to proximal. The latissimus dorsi is brought from caudal to cranial. And the omotransversarius and trapezius muscles are brought from cranial to caudal. And these are closed together using a simple continuous appositional suture pattern, as shown here. Notice the muscles are offering a very secure and a very protected layer over the exposed chest wall. The skin is then closed in a triangular form, and the operation is complete. Here is the patient that just received the amputation that you saw, and this is 1 day post-operatively. Quadrupeds do very well with a forelimb or hind limb amputation. It takes very little time for them to become accustomed to utilizing their three-legged tripod stance in order to adequately ambulate. And after several months, these patients are almost completely back to normal in any of their previous functions before they had their amputation. Here you can see this dog doing quite well.